Okay, good morning, everyone. We've managed, we're here and ready to start. So let me just introduce Dr. Daniel Lee. He's a clinical professor of medicine at the University of California, San Diego School of Medicine. He received his Bachelor of Science degree at the University of California, Los Angeles in biology, and subsequently attended the UCSD School of Medicine to receive his MD degree. He completed his internal medicine residency program at UCSD Medical Center and HIV fellowship at the UCSD Owen Clinic, which is a clinic specialized in the care of people living with HIV. In 1999, he joined the Owen Clinic as a faculty and has remained actively involved in HIV clinical care, clinical research, as well as teaching and mentoring UCSD medical students, residents, and fellows. Dr. Lee is the medical director of the Owen Lipid Lipodystrophy Clinic, which is a subspecialty clinic, which he started in 1999, focused on clinical management of metabolic complications of antiretroviral therapy and comorbidities, which include dyslipidemia, lipodystrophy, wasting, osteoporosis, frailty, and aging. Furthermore, he is a current principal investigator for the UCSD local partner of the Pacific AIDS Education Training Center, where he also serves as a medical director for the HIV Learning Network, a telehealth program associated with the Pacific AIDS Education Training Center. Dr. Lee is still actively working with the HIV community as a board president of Being Alive San Diego, a local AIDS service organization, as well as being a longtime committee member of the California-Hawaii chapter of the American Academy of HIV Medicine. Finally, he is passionate about teaching Kili meditation to patients, students, and medical providers to all levels to improve individual wellness and reduce burnout. I'll hand it off to you, Dan, and thank you so much for presenting today.
Great, thank you. Who wrote that? Long introduction over there. No. Thanks everyone for being here today, in person and online as well too. So I was asked to talk a little bit about some of the complications of antiretroviral therapy and of HIV. I think one of the things when you get to go to CROI, the penance for that is to do a grand rounds presentation like this. So I'm paying this forward. So if you haven't been to the Denver Convention Center, this is a picture of the convention center with a blue bear that's standing outside looking into the convention center. So it's kind of a neat place. So if you haven't been, you can look for this. That's how you can tell you're at the convention center. And so there's a close-up of the bear. So while I mentioned here, it says complications, the one complication I'm really going to be more focused on is really about the weight gain issue. I think that's kind of been the thing that's been forefront. I do have some disclosures listed here. And so with that said, these are the learning objectives. I'm going to cover the more recent data about the GLP-1s that I think people are starting to use much more of. I'm going to talk a little bit about what some of the mechanisms perhaps related to the weight gain. I think that is always something that isn't discussed too often. And then I'll also present some of the other interesting studies that were presented more recently. And so how this session started, at least on Monday, was this moderator by Todd Brown was the one who moderated this session about weight gain and GLP-1s. And it included mainly 3 sessions that I'm going to actually talk about each of these talks. So the first one about, well, all 3 about semaglutide, otherwise known as Wegovy or Ozempic. So Wegovy for obesity, Ozempic for people with diabetes. And so these were studies looking at the impact of these in people with HIV. So I will review that. So the first study was presented by Heidi Crane, representing the CNIX cohort. So looking at the impact of semaglutide on weight change in people with HIV. And this was a stratified analysis by baseline BMI. And so this was the study design. Very briefly, the Phoenix cohort is a group of, I believe, 5 clinics from around the country, of which Owen Clinic is one of them. And they basically collect clinical data. So at least for those at Owen Clinic, our patients, whenever they come in, have to do questionnaires. And all these questionnaires ask about pretty much every medical condition that they have. And so this database really gives people a snapshot of how people with HIV are doing, I guess, around the country. And so this database can be then tapped to look at whatever clinical questions people are interested in. So this group decided to look at the use of semaglutide during 2018 to 2022. And so people were on either oral or injectable semaglutide. And they basically looked at body weight change in terms of kilograms as well as percent body weight change. I'm not going to get too much into the more specifics. I'll try to just summarize things because there's quite a few studies I'm going to be kind of covering. So this study included, and I say only 222 people because we know that at Owen Clinic, we have at least 400 people on these agents and probably more by now. And so this was kind of an early cut, probably a few months ago. And so you can kind of see in this database about a quarter female. Average follow-up was only about a year. And so these medications have been out a bit longer now. Average age 53. Majority of these people here were being treated for diabetes. So I think this is still a little bit before the Wegovy craze that is still going on now. And so with that said, it's important to keep in mind the population that we're looking at here. So the average A1C here was 7.7. So keep in mind, this is much more of a diabetic population. I think the one caveat to mention here is that these GLP-1s tend to not work as well in terms of weight loss in people who are diabetic compared to people who are not diabetic. So we tend to see much more weight loss with non-diabetics than we do with diabetics. You can kind of see the CD4 count. And so bottom line, on average, on the bottom right here, people with HIV lost about 5.7% body weight, which came out to about 6.5 kilograms, which is over 14 pounds, probably somewhere in that range. And once again, this is in mostly diabetics. So if you extrapolate, for people who are using it for weight loss, you might even see more weight loss. And the other thing to keep in mind is I've just put in this little box here is that people were on very different doses, and about 70% were actually more on the low doses, and only 30% were on the higher doses. So it's possible there might even be more weight loss in people as you get up higher. And their main study here was looking at body mass index. And I think the thing to just notice here is that, so they have different BMI class here on the left. And so the heavier BMIs had more weight loss, right? And so bottom line is that the more you weigh, if you're on these agents, you're likely to lose more weight. And that's kind of, I think, been seen in general, even in the non-HIV studies, is that the more fat you have, the more potential you have to lose. So in other words, if they don't have too much fat, they're probably not going to benefit as much. And I don't think that that's too unexpected. So their conclusions was that semaglutide was associated with significant weight loss, whether it's kilograms lost or percentage body change within a year. And once again, they saw more weight loss in people with higher BMI and yeah, so. So my thoughts, I just kind of put on the bottom here is that this is kind of a small sample size, and of course, they're going to continue to collect more data. So I think we'll know a little bit more about maybe the population. I think we're using it now in is really people who do not have diabetes, but just have more obesity. And what about the effect of other GLP-1s? And we're starting to use other medications like tirzepatide, otherwise known as Mounjaro, for diabetes, or Zepbound for obesity. So you got to keep the names straight here. So the second study I'll talk about here was another interesting study looking at using semaglutide, and their primary outcome measure was really looking at inflammation and immune activation markers in people with HIV-associated lipodystrophy. So I think the thing to keep in mind is that this is also, I think when you're looking at people in these studies, you have to decide, are the people studied people who have obesity, or are they people who have more of this lipohypertrophy? In other words, more visceral fat accumulation. I would say then, when we're talking about obesity is likely a combination of both increased visceral fat, but also probably more subcutaneous fat. So they're kind of different populations. And I think part of the reason this study was being done, it has to do with the thought that when people have more lipohypertrophy, they have more visceral adipose tissue, which is worse from a cardiovascular standpoint. And so they're interested in looking at these inflammatory markers to see if that also improves that. So with that said, once again, this is a more specialized population. So not typically just obesity, but people who have lipohypertrophy. So that's really more the visceral adipose tissue in the upper abdomen, the hard belly that we sometimes see in our patients. And so this was a study where people were titrated up from 0.25 as the starting dose to 0.5. And they only went up to the 1 milligram dose. And there are higher doses. So this is kind of a medium dose. And this was really for like 24 weeks on the 1 milligram dosage. And so some of the things I think to note in terms of the inclusion criteria, I'll just point out here is that the waist circumference, interestingly, their requirement is only 95 centimeters for men and 94 centimeters. We're talking about waist circumference. And so that is kind of a low bar. If you're talking about people with lipohypertrophy, and many of the other studies that are looking at people with lipohypertrophy, oftentimes I think the criteria is more like 104, 105 centimeters. So just kind of pointing out that this, I think the people in this study might be people who do have some lipohypertrophy, but it's not like the people who really have a lot. And I think that's also represented here under abdominal visceral adipose tissue is that the average here is about 101 or 118. And when we talk about people who really have a lot of visceral adipose tissue, we probably use over 130. So this is really kind of a population that might have some lipohypertrophy, but it's not that bad. So I only say that because then when you look at the results, you might expect even more weight loss in people who, let's say, have bigger abdomens. So just a few things to point out. So about 60% Black race here. And I mentioned here about the abdominal visceral adipose tissue. maybe a little bit lower than the usual population if you're studying lipohypertrophy. In terms of weight, however, the weight's pretty high, so 97, 98 kilograms, so people probably closer to 200 pounds. Body mass index, 32, 33 in that range. So what are the key findings? And so the key findings are kind of listed here, and basically after 32 weeks of semaglutide, it did lead to decreases in abdominal visceral, subcutaneous adipose tissue, total adipose tissue, trunk fat, limb fat, total body fat, lean body mass, and weight, which we will come to in a second. I just want to focus a little bit on what I have here in the box, is that in this study, it suggested that there was a 30% visceral adipose tissue loss, which is actually quite a bit, and still some subcutaneous adipose tissue loss. So it's important for us because if we put people who have, let's say, a lot of lipoatrophy, it's also possible that these agents might cause people to lose more fat. So it might actually make the lipoatrophy worse. But what was interesting about this is that the data was previously presented at ID Week, and interestingly, at that time, and this is the same data, at that time, they actually presented data only showing a 13% visceral adipose tissue loss, not 30%, and also a 13% subcutaneous adipose tissue versus, I think it was 12%. But the main thing is, why is there this difference? Now all of a sudden they're presenting it's 30%. So I actually sent an email to Allison Eckert about this, and she said that there was something about the regression model that wasn't quite done right. And so I don't know what the true result is as to which one is the correct number. So I think more to come from this. But the other side of the coin is this issue with, so certainly you can see this body weight loss of about 10%, which is pretty good, right? But the big concern is this lean body mass of about 5.7%. And so the challenge is that if we are using these medications in older individuals, then I do have some concerns about, are we accelerating frailty in our population or not? And that's kind of the challenge with these agents, is that whenever you lose weight in general, you also lose not just fat, but you also lose muscle. So that's kind of the challenge with these agents. In terms of their primary endpoint, bottom line, they did see some improvements in terms of inflammatory markers that are listed here. And in terms of why that is the case, at least they were not able to fully explain these improvements by decreases in weight. But I guess the good thing is that with these agents, they do seem to be pretty good in different ways, kind of thinking like statins. They have other effects other than just directly, let's say, lowering blood sugar, et cetera. It looks like there might be some improvements on inflammatory markers. So their conclusion from this study was that, you know, semaglutide does help to decrease these biomarkers, and it does look like it can reduce certainly some of the visceral fat, but also the subcutaneous fat, with then the concern a little bit about the lean body mass. And so this last portion, well, before I get to that, so my thoughts in terms of this study is that, once again, this was only looking at the medium dose, and there may be more benefits even with the higher doses. I mentioned about this discrepancy between this visceral adipose tissue reduction data and the concern for muscle mass. So what's interesting was then this study was then presented, which kind of looks a little bit at this concern about muscle mass loss. And does that actually have any effect on muscle function? And so this was a study presented by Grace Ditzenberger looking at the use of semaglutide in the slim liver study. And to kind of get people up to speed about the slim liver study, so this was a study, looking at metabolic associated steatotic liver disease. Now, maybe the new term that's being used instead of NAFLD. And so this was a study looking at using semaglutide in population for the treatment of MASLD in people with HIV. And just like all the studies, you ramp up the dose from 0.25 to 0.5 to 1 milligram. Endpoints here, at least for the slim liver study, which I'm not going to necessarily present the whole thing, as this, what I'm going to talk about is really their sub-study. But bottom line, they were looking at percent change in intrahepatic triglycerides based on MRI. Short answer, it works to reduce triglycerides in this study. But I'm going to focus on this part of it, which is more focused on muscle. And so, as I mentioned, weight loss is typically associated by muscle loss. But what we don't know is that when you lose the muscle, I think the assumption is that if you lose more muscle, it should affect muscle function. You should have less muscle function. And so this was kind of the population here on the right side. I think things to note, body mass index is about 35.5. Weight is over 103 kilograms, which is quite a bit. And the waist circumference here is about 115. So as you can see, as I mentioned, above 104, 105 is kind of the previous, at least studies looking at more like lipohypertrophy. So these were much bigger people in this study. And so what they did was they actually looked at the muscle mass. And so if you imagine they're doing the MRI of the liver here on the right. And so the only muscle that is in this range is the psoas muscle. And so that's the muscle that they looked at in terms of seeing if that decreased with use of semaglutide. And so in terms of physical function, they did these timed chair rises and 4-meter gait speed. So basically the timed chair rise is you're sitting in a chair and you get up and down as fast as you can without using your hands to get up. So usually you have your arms crossed and you basically have to get up as many times as you can within a certain amount of time or a certain number of chair rises. And so bottom line was that they showed that there was decrease with semaglutide, there was decreased psoas muscle volume overall, and these are the different cutoffs that you can look at in terms of different race, ethnicity, age, and also looking at psoas fat here on the right. And I think the big thing is the one here, looking at people over the age of 60. They are the ones that had the most muscle loss, which I think is not that surprising. As you get older, you're probably more apt to lose a bit more muscle. So when you look at muscle function, what was interesting was that we actually saw improvements in the chair rise. So this is, you can see from baseline to week 24, people were able to do it faster, interestingly. And they actually walked a bit faster as well, too. These were not statistically significant. And the only thing that came back statistically significant was that if you look at whether or not people had a slow gait speed and you dichotomize the variable to either yes or no. And I just wonder if maybe that was partly done to find something that was significant, right? But whatever it's worth, maybe there's a trend here. So the interesting thing is that, so even if people lose weight and lose muscle, it looked like their function was actually better. So maybe there is this disconnect between necessarily, so maybe people, it's okay if people lose muscle, maybe they're still able to still function. Of course, this is just one study, all right? So the conclusion here, as I mentioned, was that physical function was preserved even though there was some muscle loss. And so my thoughts, a few things, and so as I mentioned, maybe it doesn't necessarily correlate. When you lose muscle, you lose function. I think in my clinical experience, what we see is that people are so happy to be on these agents. And as they lose weight, I think it definitely helps with their mood. They're interested in trying to be more active and do more things. And perhaps there is that effect that kind of overrides things. The one thing I did speak with Dr. Ditzenberger about this, the people that are over the age of 60, and she said there are people in that group, so it's a very small. Maybe we need to study more. And I think the other thing is that it would be nice to look at other muscles, not just the psoas muscle, but the psoas muscle, I guess, is important in terms of doing the chair stand, perhaps. But perhaps looking at other muscles might be of interest. So Todd Brown ended this issue by just presenting a few questions about, in the future. And so I think these are pertinent. So in GIP and GIP, so GIP is important because if we're starting to now use more of the tirzepatide or Mounjaro, it's a combination of a GLP-1 and a GIP. So that's hopefully in the future we'll see a little bit more in terms of if there are differences. And do these medications work differently in people with HIV? What's the effect on key organs, et cetera? What are the impacts in terms of aging and this whole concept of frailty? So those are some of the comments. And so I just wanted to let people know that I had actually written a editorial with Jacqueline Hoffman from Paris about these GLP-1s. And I think the things that I would say that's important to kind of keep in mind is I think when someone comes in with what might be obesity is really to try to figure out, is this more of truly obesity? In other words, more subcutaneous fat, so fat that you can pinch, or is it more of the lipohypertrophy, more of the visceral fat, the hard belly that people talk about that's higher in the upper belly? And I think there are different probably treatment options. And in my view, if they have more visceral adipose tissue, then you probably should use things that are more specific to visceral adipose tissue, versus if it's more subcutaneous adipose tissue, then maybe it's okay to use more of the GLP-1s. But of course, I think we will find out more. And then obviously we need to find out more about the muscle mass loss and the consequences of that in our patient population. So I'm going to switch gears. I didn't know if Anik, were there questions I should answer here or?
No, just comments about it's easier to lift a lighter gut.
Yes. True.
Yeah.
Yeah.
Just comment. Sorry. That is my comment. Thank you. Hi, Dan. Thanks. I think we share a couple of patients who are older and
Yeah.
for whom muscle mass is important, and how it can bring about and trigger, like, the old cachexia type
Yes.
effects. And so I was just gonna say that, having at least some of these like preliminary data can go a long way towards reassurance of, you can still continue to work out in your do weight-bearing exercises in your seventies. And that this doesn't have to detract from that.
Yeah, I agree. I don't think these medications are necessarily, the GLP-1s are necessarily a complete contraindication in our older people. But I do think it's important that for everyone who's on a GLP-1, no matter what age, is for them to still maintain some level of physicality, to try to maintain some level of muscle mass. And especially as people get older, the tendency is just going to be to lose more muscle. And, we want people to still maintain their independence as they get older. And the challenge we see is that as people get older, they get more sedentary. And then as you get more sedentary, then, the weight starts to rise, and then you get concerned about falls, and, kind of starts that whole cycle. So, yeah, thank you. Any other thoughts?
There's a comment in the chat. Is HNRP planning to do a study to see if there is improved cognition in those on GLP-1?
That's a great question. I have not heard anything about that, but I should say that Ron Ellis and I've been a part of a study looking at tesamorelin, which is growth hormone releasing factor for reducing lipohypertrophy, that did look at cognitive effects. There's some thought that perhaps growth hormone and growth hormone products might actually help with cognitive function. That was actually presented at CROI. Unfortunately, we did not see any significant improvements. There may be a small signal still there. That's a whole nother issue, but not sure about the GLP-1s. I have not heard about that.
And actually, Ron Ellis said, no plan at this time, would love to see it done, not necessarily in HIV only.
Yes.
And
right.
Scott is happy to help with that.
Okay. Sounds like another project, Ron. So we can perhaps make it work. And I think for that study, there are a lot of people that are interested in getting on these agents. So I think we would not have too much of a problem trying to recruit for something like that. All right, for the sake of time, I'm going to move on. I'm going to talk a little bit about two mechanism studies, which I think are interesting because we still don't really understand why people might gain weight. And so the first one I'm going to talk about, it's a more basic science talk, and I've tried to just distill it on one slide because I don't want to show you all the basic science stuff. So I'll try to explain it hopefully succinctly. And so we know that integrase inhibitors as well as TAF has been at least perhaps associated with the weight gain. And what we've seen is that women tend to be more susceptible to the weight gain, or we see more of the fat, the weight gain, especially the fat gain in women more than in men. And so this group actually looked at some of the basic science, looking at dolutegravir more specifically as to whether or not this pertains also to other integrase inhibitors like bictegravir, probably. But their hypothesis was looking at dolutegravir and whether or not it may inhibit thermogenesis. So thermogenesis has to do with more brown fat or beige fat. So this is kind of like the baby fat that we all have when we're infants. And then as we get older, we kind of lose it. And brown fat tends to be more in areas of kind of where the visceral fat is. So you can think more like visceral adipose tissue in the abdomen, but also like the back of the neck. So what kind of the lipohypertrophy that we see with like the buffalo humps. Maybe more associated with brown fat. And the thought is that perhaps dolutegravir might inhibit thermogenesis and therefore lead to perhaps more weight gain to kind of deal with, let's say, cold weather, right? So you tend to gain more fat for more cushion and more, insulation, so to speak. Right. And so this group had looked at mice looking at dolutegravir And what they were able to show was that giving dolutegravir to mice reduces energy expenditure. And there's this hormone called UCP1 uncoupling protein. And if you probably don't remember from my last talk last year, we talked about uncoupling protein and the relationship with that enzyme, perhaps with kind of this fat accumulation. So this is the kind of a continuing study from the last time. In short, I'll just have you focus here on the right, is that dolutegravir apparently directly interferes with estradiol or estrogen in the hypothalamus, and you can see in this diagram E2 is estrogen, right? And what happens there is that reduces brown fat here and also beige fat. And so it leads to more of this white fat accumulation, and therefore you have less, I guess it inhibits thermogenesis, and therefore you tend to gain more fat and lead to weight gain. So in short, maybe there is a mechanism to explain perhaps why women who have more estrogen may be at higher risk for weight gain. That's all I'll say. It's more technical than that. The other interesting study is kind of this one, looking at perhaps the mechanism of why TDF actually leads to weight loss, because we don't really know why that is the case, right? And so that's something that we've been seeing more recently. And so this was a study looking at the effect of both TDF as well as TAF on the duodenal enterocytes. So basically the lining cells of the duodenum. And what is known apparently is that TDF, not TAF, is actually absorbed from the proximal duodenum and then processed into free tenofovir within enterocytes. And so their hypothesis here was whether or not tenofovir TDF damages the enterocytes, and that leads perhaps to reduced absorption of nutrients from the site. And so therefore, if you're not absorbing things, then maybe you lose weight, right? And that's kind of the thought perhaps. And so this was a study looking at 12 people on TDF, 12 people on TAF. They actually underwent gastroscopy, had biopsies done of the proximal and distal duodenum. There's something called serum intestinal fatty acid binding protein, IFABP. And this is a marker of enterocyte damage, which I'll show you some data. And they also looked at plasma and serum concentration of nutrients that are absorbed, as well as then there was histochemical staining, electron microscopy to look actually at looking for mitochondrial damage. And so these are just some of the baseline characteristics. So interestingly, there were all male participants here. CD4 counts were very different in both of these groups, 901 versus 599. These groups were matched based on the third agent that was being used. And so about 60% on an integrase inhibitor, 40% on non-nucleoside. Age was about 55. So when they did these scopes, what they found was that 5 people in the TDF group actually had some GI findings, which included celiac disease, H. pylori gastritis, and esophagitis, and maybe less were only 2 in the TAF group. 2 episodes of esophagitis was seen to have a pathologic finding. Unfortunately, it didn't really say how long people were on these agents, but I think it's kind of assumed they've been on it for a while. And what was seen was that the duodenal villi, which are kind of like the finger-like projections in the duodenum, and ideally you want, so if you look at my fingers, right, you can say that you want more fingers because there's more surface area to absorb things. And so in the study, they were less existent and maybe stubbier, as well as, So less surface area, you can think of it that way. And so that was manifested by these, can't see here on the right because it's super small, but looking at the villus height, the height of these, as well as this other ratio. And that was different in the lower in the TDF group. So this is TDF. Did you see, you don't really see the fingers here. Here, maybe you see some of the fingers. But even with that, I would say that even TAF, there was some effect. When we look at enterocyte damage by IFABP, there was significantly more damage in the TDF than the TAF group. So that kind of went along with their hypothesis. And the TDF had numerically lower plasma and serum concentrations of various vitamins. So we were talking about absorption of nutritional like supplements and stuff like that. And that was so numerically lower, but not statistically significant. And then when they looked at like mitochondrial damage staining, what they saw was that both groups, 10 of 11 and even 11 of 12, showed mitochondrial damage. So not just the TDF group, but even in the TAF group, there was mitochondrial damage. And so as to what that means for all of us, I don't know. I guess we'll have to see. And then electron microscopy shown over here, bottom line, all the samples showed some mitochondrial damage. So I think it's interesting, at least this is the first study I've seen in regards to maybe helping to explain why maybe TDF, there's some weight loss. Is this really what is going on and causing that? So I think it's provocative. I think there's probably more that needs to be done to kind of make that conclusion.
What's your thought?
About, is that the case? It's the only thing that we've seen so far, at least that I've seen so far, that might, but I presume you have a theory. Lala. You must have a theory.
You know, the history of mitochondrial effects in the acceptor changes from the history of antiretroviral therapy. But I will start with a premise. TDF doesn't necessarily produce weight loss. TAF produce weight gain.
So that's been kind of the conundrum, is what causes what, because is TDF truly weight losing and maybe TAF is neutral, or is TAF really weight gaining? We don't know relatively what is the truth. But I don't know. Yeah, I mean, I think that there is certainly, I think what's perhaps concerning is that there is mitochondrial damage with either agent, if you believe this data. And I've talked certainly with the company and I've heard conflicting things. Some say that, there's no mitochondrial damage with TAF, but I think it depends on, how deep are you looking, and is this a clinically significant damage? Those answers, I don't think we know. So, yeah.
There's a comment from Nettie. I feel like there is still a lot of bias out there trying to explain why TAF is still superior and pile on evidence against TDF. I think those who gain weight on TAF, which is many people, will argue that we are splitting hairs if we try to convince ourselves that even though they had normal weight on TDF, TAF is still better. The patients don't care if TDF is weight losing and TAF is neutral. They care about where they sit on their scale. I suppose that was what you meant.
Yeah. Yeah, I think, thank you, Nettie. I think that's you just put it out, what's practical and what our patients care about. But certainly I think it's helpful for us to know what the exact mechanisms and whether or not, are we contributing to some of the changes that we're seeing. But I think that is the practical question is from a patient standpoint is if there's potential damage, but they don't see it, do you need to change their regimen? right? And if they're okay with it, right? So no exact answers here, I think, but more kind of food for thought. So I'm gonna talk about our last few studies if I can. I think I can probably get through it. So I just thought about, there's 3 other interesting studies in this kind of related area that might be of interest to people. So the first one I'm going to mention a little bit is this study about weight gain after initiating antiretroviral therapy close to HIV seroconversion. Is there a return to health effect? And so to kind of put it into perspective, we oftentimes think that someone with HIV, let's say if they've been diagnosed for a little bit of time, and is that when you start antiretroviral therapy, there is this effect called the return to health effect. And from a weight standpoint, the thought is that if someone is HIV positive, their tendency over time is to lose weight. And when you start them on antiretroviral therapy, they have the potential to regain the weight that they may have lost. And so this is what we call the return to health effect. To try to get rid of that effect, this group decided to study people who just recently seroconverted within the first year. And the thought is that if it happens, if you can capture people early enough, shouldn't be this return to health phenomenon that happens. And so kind of an interesting study to look at that scenario. And so this was a study looking at the Cascade collaboration, which I find interesting that it's funded by many of the companies, ViiV, Janssen, and Merck, looking at people who started first-line antiretroviral therapy after 2007. And so people could be on an INSTI, an NNRTI, or a PI regimen. And so there are close to 5,700 people. Majority were, almost half were on integrase inhibitors, about a third on PIs, and about 20% on a non-nucleoside regimen. These are some of the baseline characteristics and what they are on. I'll just kind of point to the bottom here in terms of, if you look at the percentage of people who gained either more than 5% versus more than 10% after 3 years of being on antiretroviral therapy, you still see that the integrase inhibitor group people tended to gain more weight than the PI group, but also the non-nuc group still does gain weight. And this is in people who more recently seroconverted within a year. So maybe a little bit surprising, because you might expect maybe you shouldn't see this amount of weight gain in people, but we're going to talk about that.
What was the backbone in this? Sorry.
So the backbone is could be anything. So here it just says TAF about 17%, mostly with INSTIs and BIC in particular. And so keep in mind, this is 2007, so there were probably some AZT backbones in that as well too. So there was a question, yes.
Quite active in the chat. So there was first regarding the previous one, is this true? Injectable should avoid this. I guess the kind of effect on the gut. If it's injected, it doesn't go through the gut, right? That's my interpretation of the question, but I
yeah. So like injectable antiretroviral therapy.
Yeah.
Yeah, maybe. I don't know. Yeah.
And then Tom Martin said, if there is duodenal enterocyte damage with TDF, is there any evidence of malabsorption of proximal duodenum nutrients like iron and fat-soluble vitamins in addition to weight loss?
Yeah, so that was on this one right here. Second bullet.
Okay. And then Jeff Taylor said, it would be interesting to see a comparison of these approaches to old-fashioned diet and exercise. Given how hard it is to get sizable diet and exercise studies funded, I fear we're going to favor these medical interventions over diet and exercise without sufficient data to prove that one is actually better than the other.
Absolutely agree. And I think they all should be done with the diet and exercise component. Of course, as Jeff, as you know, it's not the easiest to kind of get those kinds of studies done and achieved, but yes.
And then there was a last comment by Tom
Okay.
saying, and include a duration effect after the intervention is discontinued, something conveniently not done during the GLP-1 weight loss trials. So comparing the
Yeah.
diet versus the drugs.
Yeah, okay. All right. So very small here, I get it, I'm sorry. So coming back to this study, I think some of the things to notice, so this is looking at BMI category on the left here, and then they also looked at weight change, estimated weight change based at either 6 months or 3 years for each of the different body mass index categories. I think in general, I'm just putting this in a box showing that with insties and even with PIs, it's somewhere between 1.5 to let's say 3 kilograms. If you compare to the non-nucleoside, the weight gain is much less here. And then, but when you look at both TAF and then the TAF and INSTI groups, they're all in this 2, 3, 4 range. So I think relatively more weight gain at least was seen here, even in TAF and the TAF plus INSTIs. Here on the right of that is basically looking at the weight changes. So different BMI strata. So this is the lowest here. And then to the right of that is the next kind of the normal strata, normal BMI. This is overweight on the bottom left. And then the bottom right is the obese strata. Basically just looking at the trajectories. I would say there's still kind of this increasing trajectory with all of the regimens. And so the conclusion I've just tried to kind of highlight here is that greater weight gain was seen among those on these regimens is unlikely, at least their conclusions, was unlikely to reflect a return to health effect. And their conclusion was that this is really more of a direct effect of the drugs themselves, because in this group, they're capturing people perhaps without the return to health effect happening. So Lalo, do you have a comment?
A question. Do you remember which clinical factors they adjusted for? It's just not about the
yeah.
timing of seroconversion.
Yeah, I don't. And I think the other caveat here is that the date of seroconversion does not, so someone can have HIV for 10 years and then seroconvert positive because they finally get tested. Those people will have a return to health phenomenon that perhaps is what we are seeing here, because when I look at these curves, the initial rise in the weight is usually the return to health phenomenon. And then the flatter part of this line and this middle part usually represents the normal weight gain that we see in the general population. So I still think you still see a return to health phenomenon, and it might be because, as I said, with seroconversion, they might still include people who are late in care, late diagnosis. Those people will still have a return to health. And, you know, plus all the perhaps other parameters you're talking about that are not captured here.
No, to your point, it's exactly to your point. We learned this in the early 1990s.
Mhm.
We don't know when they were infected, but the most important correlate was the CD4 cell count.
Yep.
Right.
CD4 nadir.
It's not the same to being diagnosed with 750,
Correct.
then 250, and then when you accept
Yeah.
it.
So I didn't see the CD4 nadir on this, but you're absolutely right. That would be important to see on here, because I think that's more of a marker of this return to health issue.
So how was the circumversion calculated?
How was,
Or how was it detected? How was it calculated? They were in 1 year, within 1 year.
I'm sorry, I'm not.
Were they known as seroconverters and
You'd have like a negative test or something.
Yeah,
No.
yeah, I presume it was you know, they had to have a diagnosis and then into care and on treatment.
Like they happen to have a date of HIV negative testing or something like that.
Yeah, see,
Oh.
that
Oh, then I really don't know. Yeah, I mean,
Yeah.
I go back to, like, I mean, I'm just thinking of, I worked in, Dr. Little's, acute and early
Yeah.
infectious HIV cohort for such a long time. I mean, so much energy and expense went into actually diagnosing people in
Right.
acute and early HIV infection.
Sure.
These are what this study is trying to describe, people that,
yeah,
if you had real,
Big
true
stage.
seroconversion, yeah,
yeah,
exactly.
yeah,
Not, I
yeah,
mean, you might argue that at 6 months or even a year already, some of the effects of HIV are, already taken effect.
yeah, and yeah, I mean, these would be the questions to ask these investigators, but I don't know.
We've got 3 minutes just in case.
Yes.
Just real quick
Okay.
on that eyeball, look, like
Yes.
it does look like there's a real steep rise in
The
the
middle.
return to health. Are they saying that that just,
So,
wasn't statistically?
yeah, so the challenge here is that there's only 2 data points.
Hmm.
6 months and 3 years.
Yeah, yeah,
So it does also look more that way, but there are only 2 data points.
okay.
Or 3 from 0, 6 months, 3 years. So, yeah, hard to say a lot about. So I got my 3-minute time, and so I'm gonna give you the last 2 studies in 3 minutes.
More like
So
2 minutes.
people are in 2 minutes now. So people are interested in about switching and changing medications. I thought this was interesting. Looking at weight change after starting doravirine in people who are antiretroviral experienced in the US. So this was looking at the OPERA cohort, which is most of AHF clinics around the country. And so this is looking at people starting doravirine in people who are already experienced on antiretroviral therapy, stable, switching to doravirine. I think the short skinny is the table on the right is that with both men and women and overall, you see this kind of slow decline in weight. So interestingly, switching to doravirine at least looks like it might be helpful. I'm going to try to skip to the conclusion here. And so what they saw was doravirine was associated with a modest but statistically significant weight loss overall, especially in women, and that's seen up here on the table in the top right. And they said patterns of use in terms of antiretroviral therapy did not fully explain the weight loss. But I thought this is interesting if you're looking for an intervention, not that we still recommend that you switch antiretroviral therapy, but there is a suggestion that maybe doravirine can cause some weight loss. The last study is just going to show you here is that this is comparing weight gain in people with and without HIV over a 3-month or 3-year period. I'm just going to kind of get to the conclusion here. And what they were able to show is that after adjusting for differences in characteristics, there really was in unmatched data, maybe there's a slight more weight gain in people with HIV, but when you matched with people without HIV, it looked like the weight change was similar. So they're trying to make the fact that perhaps the weight gain that we are seeing is not necessarily an HIV issue, but it's just the normal weight gain that we see in the general population. So I'll stop there. There may be more
Amazing.
questions.
9 a.m. exactly.
All right. Any thoughts, comments? Email me if you have questions.
There was